I'm happy to host yet another important program for the IAGES Primetime. Today we have the most important issue being addressed by the most eminent faculty across the country. May I have the honor of inviting and introducing our president, Professor Sunil Papat, who has been having a tough because of Corona, and later he has been traveling extensively because IAGS has huge amount of academic program both on fellowship areas, both basic and advanced fellowships, and he has been instrumental in bringing in new subjects and new specialty fellowships also. Sir is an eminent foregut surgeon with special interest on interventional endotherapy as well. Sir has been at various positions of the IAGS, and he has ascended rightly in the right time for the presidency of the IAGS. And he's brought in important changes and developmental activities for the IAGS. And he's been instrumental in bringing in new relationship with many societies in and out of the country. May I have the honor of inviting Professor Sunil Papat, our president, to give the presidential welcome. Over to you, sir.
Thank you, Dr. Aman Goel, for the kind words. Good evening, friends. Good evening, faculties, to this very important program tonight on IGS Prime Time. Tonight, we are discussing regarding the paper writing, publishing, why to do research, why the articles are rejected. And you cannot find better faculties than what we have tonight. We have our two editors from JMAS, Dr. Anil Sharma and Dr. Sandeep Agarwal. We have our past president and editor of Bariatric Surgery, Journal of Bariatric Surgery, Dr. Aman Goel. And we have Professor Rajiv Kumar from AIMS, who is the associate editor on the board of Indian Journal of Urology. Friends, IAGS has been at the forefront of the academic activities all throughout last 3 decades. Various fellowships have been planned and executed in basics of laparoscopic surgery, in various advanced subspecialty of laparoscopic surgery, such as upper GI surgery, bariatric surgery, HPB surgery, onco surgery, hernias. This year, we have been successful in introducing PALS robotics, that is the Advanced Laparoscopic Surgery Fellowship in Robotics. We had our first PALS course very recently in New Delhi. Also this year, we introduced Safe Lap-Chole skill course and also introducing laparoscopic hernia skill course. IAGS is at the forefront of teaching and training and skill imparting for the laparoscopic surgeons and GI endoscopists. Friends, not only on the offline platform, but also on the online platform with the IAGS Prime Time, various master classes, and collaborative international webinar with ALS GBI. IAGS has been catering various academic programs to the surgeons of India and abroad. IAGS Prime Time, which was started last year under the leadership of my friend Dr. Aman Goel, has progressed to a new height and has achieved international clientele all across the world. I am very happy to invite you all for tonight's show of IAGS Primetime. I am sure India is not lagging behind in research and publication. The new generation is coming up with great ideas and they are very eager to publish and do some research. And this is the right platform to give you some guidance regarding how to do publication and how to do research. I invite you all to IAGS National Congress at Rajmundry in February 2022. And I'm sure you will all enjoy tonight's program. Over to Dr. Aman Goel to start the program. Thank you all very much.
Thank you, President, for guiding us through in this difficult phase of pandemic into all the galaxy of academic program. Thank you very much. Ladies and gentlemen, now I have the honor of hosting this program for you on various issues of writing, publications, what are the challenges a writer faces and what are the challenges the editor faces. All those things have been going to be addressed by very eminent speakers. Now, I have the honor of introducing the first speaker, none other than Professor Rajiv Kumar. Professor Rajiv Kumar is head of the urology at the All India Institute of Medical Sciences. Professor Rajiv has been the chief editor for the Indian Journal of Urology, and he is also holding very important, eminent editorial board positions at various national and international journals. In the National Forum, the National Medical Journal, and across the globe, Journal of Urology and the entire gamut of urology. So, beyond which, he has special interest on especially the robotic urology, the surgery of the adrenal gland, and he specializes on microsurgery for male infertility also. And he is currently pursuing research on magnetic resonance techniques for prostate cancer. And more so, to add multiple feathers on his cap, he has huge number of medals to be backed from the time of medicine and to the general surgery and into the urology, and has been awarded many international scholarships, outstanding urologist awards, and many fellowships, including the most coveted ICRET fellowship of the UICC. Ladies and gentlemen, may I have the honor of inviting Professor Rajiv Kumar to speak about and enlighten us how to decide on authorship, misconduct in scientific writing. Over to you, Professor Rajiv Kumar.
Thank you very much for the very kind invitation and for that introduction. It's really kind of you to have given me such a nice introduction. Members of the IAGES Society, Dr. Sandeep Agarwal and Professor Popper, the President, thank you again for this invitation. I would just like to make a small correction. I am not the head of the Department of Urology at my institution. I am a professor of urology at the institution. I will be talking to you over the next 20 minutes or so on authorship and misconduct. The topic is slightly out of line with your other 4 talks, but I had requested Sandeep, who's a very close friend, to let me go first because of another conflict. So I thank you for allowing me to go first. Authorship and misconduct are 2 of the extremely important aspects of when we get down to write. Of course, you have to have something to write. You have to have a publication, or you have to have a paper in hand before you can even think about issues like authorship and misconduct. But over the years, we've come to realize that some of the most important places where people get stuck at times is actually on deciding authorship. And the other place where they make a mistake is in regions of misconduct. And to a large extent, it's because they've never learned what is the right thing to do. And as we move towards the end of my 20-minute talk, you'd realize how important this is today, when everything can be searched on Google, every misconduct can be highlighted very easily, and the repercussions are very severe. So just to begin by talking about what exactly is misconduct, I have a very small, brief definition for it. Misconduct is something which is more about ethics than it is about the rules or than it is about the law. It talks about things where some people may actually differ with others about whether there actually was misconduct or not. So often there are areas which are gray. And you talk about things which are ethically acceptable to your peers, rather than saying that this is breaking the law. So of course, there's one extreme where you would possibly be breaking the law. But a bulk of our issues actually focus on things which are debatable. And therefore, the question often that you need to pose to yourself is, would I be embarrassed if somebody found out that I had done this? And if the answer to that question is yes, then it's probably misconduct. That's the simplest definition I use in everyday practice. When we talk about misconduct, misconduct involves the entire research cycle. From initial designing the study, from posing a research question, to its conduct, its evaluation, its writing, its reviewing, and its publication. Entire cycle, it has places where misconduct would occur. What we're going to focus on today are just a small aspect of it. We're not even talking about the research or the review misconduct. We will look simply at authorship, plagiarism, bias, and submission. Just 4 topics. And among these, I will specifically focus on authorship because that's what I was asked to speak about. And whenever we talk about misconduct, again, like I said in the beginning, there are certain things which you know are wrong. So for example, if you had operated on 20 patients, but you reported on 40 of them because you believe that whatever happens to 20 must also happen to the next 20. So you could just multiply the average by 4. That is clear fabrication, and that doesn't require an ethicist to tell you that it's wrong. At the same time, when you saw that you had 20 patients, all of them did well, but one patient ended up dying, and you decided to report only on the 19 who survived, and you quietly omitted the one patient who died from your series, that's an omission, and that's clearly misconduct. On the other hand, the bulk of the misconduct that typically happens is on the right side of what you see on this slide, and that's relatively debatable. You may have made a mistake in terms of your sample size or recording errors. Now, these errors would possibly mean that your results aren't valid. They also may mean that your conclusion isn't valid, but they aren't going to be penalized as heavily as when somebody finds out that you've either falsified data or fabricated data. So there is an entire scope of misconduct, from one which is assumed to be an error to one which is assumed to be an act of commission or cheating. Fortunately, the first misconduct that we're going to talk about doesn't often come into the extreme left area, or doesn't usually become an extreme area of punitive punishments. So the question here is that let's look at any clinical department. It doesn't even have to be an academic department. You don't have to be a professor or an associate professor. You just have to have a bunch of 4 people working together in a department. They have certain residents and they work with each other, and each resident writes probably one paper or gets data together for one paper. Some people among this group are friends, and therefore they say, you put my name on your paper, I'll put your name on my paper, and both of us will therefore end up having more papers. And the head, of course, says I have to have my name on everybody's paper, and therefore he ends up having more than anybody else. So what is the harm? Exactly the question again, what is the harm? So what if instead of my paper having 3 authors, it has 4 authors? What if somebody else's paper, instead of having 4 authors, gets 5 authors? How does it make a difference? The data is genuine. We've done the research, we're publishing the research in a good journal. And so why is anybody bothered if there is one extra person named on that authorship? Why is authorship such a big issue? So over the next 10 minutes, I'm going to try and convince you why this is important, because it's only when everybody realizes that this is truly an issue, and it goes beyond just egos. It's not just about saying that I'll put your name only if you put my name. So it's not just about a give and take or an ego, but the issue goes beyond that. And if I'm able to convince you in the next 10 minutes or so, that is what the objective would be, to talk about authorship. So let's look at this statement from the International Committee of Medical Journal Editors, or the ICMJE. The ICMJE is a body of editors. It initially began with the big 5 journals, including the Lancet, JAMA, New England Journal of Medicine, Annals of Internal Medicine. But it's subsequently expanded to include a large number of journals, including the National Medical Journal of India, which was a member on the ICMJE a few years back. And guidelines that the ICMJE puts out are often used by most journals in writing their instructions to authors. And the statement on authorship from the ICMJE states that the author must take responsibility for the work. And I'm not reading the whole thing, and unfortunately this box has moved a little bit, but the highlight was supposed to be on the word responsibility. The most important operative word for this statement on who should be an author is the concept of responsibility. Now, responsibility, unfortunately, is a very tenuous definition. I can be responsible. There are 5 of us who are working in a department. We're reporting on 100 cases of radical prostatectomies. I did 5 of them, so I have responsibility. I should be an author on it. Is that responsibility? Is that enough to make me an author on that paper? So since it's very difficult to give a measurable definition to responsibility, the ICMJE actually came up with 4 clearly defined criteria. And it says that if you can say yes to every one of these criteria, you deserve to be an author. So the single most important, the first most important criteria is you must have a substantial contribution. And the contribution could be to the design, the thought process, the concept, the analysis, interpretation. It's very wide. It doesn't necessarily mean that you have to have gone there and collected all the data. You could have just thought about the idea. You could have just given the concept and the design, and that's enough as an important contribution. Then you must have contributed to the writing up of the paper, either the drafting it or the revision. Then you must also have approved the final version of the paper. And another important, called the fourth criteria, was actually introduced very recently in 2013, which said you must be accountable for all aspects of the work. Now, this is where the problems start coming in, and this is where responsibility starts getting assigned. What this says is that you can't get away by saying that, okay, let me give you an example to make it simple. Let's say you wrote up a paper. You wrote up a paper on, let's say, 100 laparoscopic cholecystectomies, and you were looking at a certain biomarker to say whether a biomarker could predict complications of cholecystectomy. Let's say you were analyzing the bile that we're taking out from the gallbladder and doing some biochemical analysis to say likelihood of complications. You wrote up a paper, you had about 200 cases, you published the paper, and about 3 days after the paper was published, somebody writes to the journal saying this work is fraud. The test that was done on the bile is not even available in the hospital where this paper has come from. Now, you as a surgeon would say, where is my fault here? I have done the surgery, I have all those cases, I have the data, we collected the data, I have sent it to the lab, the person I collaborated with in the lab said they will do the test. How am I responsible if the lab actually did not do the test? Where is it my responsibility? This is where the concept of responsibility comes in. And that's where the concept of responsibility says, no, you are also responsible. Because ultimately, when you collaborate with somebody to write a piece of work, you should have faith and you should have trust in the person that you're collaborating with to ensure that they are also speaking the truth on your paper. When you write such a paper and there is a reader sitting in Timbuktu who's reading your paper, that person will never be able to identify that there is no such lab in your hospital. It's your job to ensure that even the lab work that is done, that is being reported on your paper, is truthful. That's what's most important about authorship. It means that you must have ability to vouch for all aspects of the work or be able to identify who is responsible for which part of your work. So what do we do about people who don't actually fulfill criteria? So there are two terms that are used to describe such people. They're called ghosts and guests. Individuals who do not fulfill all the four criteria but get their name listed on the paper are called guests. They're also called gifts authors or guest authors. The other set of people are people who actually should be authors, but they don't get their names on the paper, and they're called ghosts. So why is this? Why does this happen? And why is this important? Why are there ghosts? Why are there guests? So let me give you an example to help you understand why this becomes important. Let's assume you read a research paper in the New England Journal of Medicine. It's a randomized controlled trial. It's been actually done by a top-level researcher at a top-level institution. There is no doubt about the quality and the ethics of the work, and it's actually a genuinely well-done research. And this research says that a new drug X is better than a new drug Y. Most of us would then be inclined to accepting it and possibly prescribing drug X. Now let's assume that the very next week, the New England Journal of Medicine publishes another study. This study again comes from a top-level researcher. The study is just as brilliantly done as the first study. And take it from me, the studies are really genuinely well done. Both studies are no flaw, ethically or quality-wise, no flaw. This study now says that drug X is not better than drug Y. Now, when we read this paper, we end up in a little bit of a dilemma. Maybe the drug is good, maybe the drug is not good. Both studies are equally good. One says good, one says not good. So maybe there is a doubt. Now let's look at this a week later, and somebody comes up in the press and tells us that the author of the first study owns the company which makes drug X. Now, what is our natural reaction? Our natural reaction would be to say, the first guy is making money. That's why his study found the drug to be good. Now, as a natural reaction, again, I would tend to put more faith in study 2, which would say that maybe it actually doesn't work. And the first guy was making money on it. That's why he showed that the drug X is better than drug Y. Now, this reaction that I've just had or tried to enunciate is a very natural reaction, and it's based on real facts. What we've shown here is a conflict of interest. And because of this conflict of interest, our faith in study 1 decreases. Even though I said the study was perfect, I began my entire case presentation by saying the study is actually perfect. Now, since the author of study 1 knows that this is the human reaction, just because I own shares in this company, nobody will believe my study, even though I do a perfect study. What he does is keeps his name off the authorship. He would rather have the study published than have people questioning his research just because he's an author on it. This is called a ghost author. And this is one of the most important aspects of authorship misconduct, where conflicts of interest are hidden through ghost authorships. On the other hand, when we look at the concept of gift authorships, each one of us is fully aware that every paper in a big institution gets 5 padded names. The senior boss gets added, the third boss gets added, and we assume that it's because they demand it. The HOD demands his name to be on every paper, and therefore he's a gift author. Now, while that may very well be true, there is another reason why his name is on the paper. When a new young assistant professor, a young faculty, a young resident submits a paper to a small journal, let's say you're submitting a paper to the JMAS, it's quite likely the editors don't know who you are, don't know your institution, and the confidence in your data is a little low. You also know that, and therefore you rather ask somebody senior to put his name on the paper, knowing that having his or her name on the paper certainly gives greater credibility to your paper. And you certainly know that Dr. Sandeep Agarwal would recognize this person's name and would trust the paper more than he would trust me because he doesn't know me. Therefore, you are trying to buy trust by putting in a guest author on your paper. So guest authorship isn't always the fault of the guest himself. You may always blame the HOD saying, I always have to put the HOD on my paper, therefore he's a guest author. Sometimes you're actually using his name to sell your paper. Both of these are a problem because, like I said right in the beginning, everybody believes what you say in a paper. Out of the 1,000-odd papers that are published, do you ever go back and verify whether anything actually occurred? You see a new paper which says, let's say, remdesivir works for COVID. One paper comes out, 1,000 patients, we gave remdesivir and they did better in COVID. You start using it tomorrow. How many times will you actually go back to that hospital and did they ever even treat 1,000 patients of COVID? You don't do that. You trust them. And very rarely do you find out that they actually cheated. That's why there is a responsibility when you put in people's name in authorship, because when you do find fault, everybody, all the guests, all the HODs, all the people whose name you put in will have to take responsibility for that paper. And unfortunately, guest authorship doesn't stick to just simple papers. People are doing it in thesis as well. So it's not uncommon anymore to find notices such as this. This has been taken from the AIMS hostels a few years back, where people are told, just join a department, tell me which department you're working in, and I'll give you your thesis. And depending on how much money you pay me, I can give you the introduction, the methodology, the literature review, or the whole thesis. It just depends upon what you're willing to pay me. This is an extreme example of where authorship misconduct is going. So a lot of people who've helped you on the research, help you with the funding, collection of data, stuff like that, you may acknowledge them. You're grateful to them because without them, your research probably would not have been possible. So you wish to give them credit, that's fine. That's called acknowledgement. That's not authorship. So acknowledgement could be anybody who's given you technical help, somebody who's helped you write parts of the section in which you have to acknowledge him, data collection, lots of bits and pieces, which you truly believe is essential. I mean, you don't end up thanking everybody in your department for helping you complete your research. That's not an acknowledgement that should go into a paper. Or I thank my family for being with me while I was writing my paper. That's not an acknowledgement. But everything else is acknowledgement and not authorship. And finally, one word about position on the byline. Should he be the first author? Should he be the second author? Should he be the last author? Now, this has become a bit of a confusing issue because of regulations which came up from the Medical Council of India, where faculty would get credit only for certain specific positions on the authorship. Classically, there are two positions which by convention carry certain weight. The first author is generally presumed to be the person who's done the maximum amount of work on that paper. The corresponding author is characteristically presumed to be the person who's the overall supervisor. Although for a journal, the corresponding author is simply the guy who's writing back and forth. But by convention, these are the two positions, and this is what it means. And therefore, again, if you're a faculty in a teaching institution and you've given a thesis to a student, I would be very surprised if the student wasn't the first author and you yourself are not the corresponding author. For you to say that, no, I will be the first author, there must be some really strong reasons. So the bottom line on authorship is follow the ICMJ guidelines, avoid getting into disputes by discussing authorship, particularly if you're doing a collaborative study with other departments. Try and discuss it before you get into a dispute that let's write a paper, this is the collaborative research work we're doing, and so will be the author, you'll be the second author. And you must always get approval from all your authors before you submit a paper. Even if it's just on email, circulating it to everyone, that's good enough, but you must get it. Now, very little time on the other few. I'm just going to take 3 to 4 minutes on the other things. This is not where I'm focusing. So the next issue is plagiarism. And plagiarism, in very simple language, is cheating, stealing. It basically means taking that which is not yours. And that doesn't necessarily mean just words. It means figures, diagrams, tables, paper, even ideas. Just the flow of a paper. Let me take the example of cholecystectomy again. You write a paper on short-term complications of robotic cholecystectomy. Now, you've read another paper which described it as incidents of bleeding, incidents of bile duct injuries, incidents of liver injuries, incidents of atelectasis. 4 headings, they discuss their complications. You write a paper, again discussing it in exactly the same 4 headings. Now, that also is plagiarism. You may say the data is mine, I have done all the research, all this, I can verify everything, that's fine. But you can't be copying somebody else's thought process or idea. So that's a very broad definition of plagiarism. And the commonest errors, of course, that we see are people copying text and paragraphs. And the simple explanation is, I don't know English. I can't write English well. I've read somebody else's English. I think they've written it very well. I've just copy pasted that, but the entire data is mine. The data is genuine. So you may be right. The data is entirely yours, but you still can't copy paste on somebody else's paper. And the commonest places where this error occurs is in the introduction and the discussion, because that's where you have to write on your own. The methods and the results are pretty much standard. It's very difficult to cheat there, although people manage to do that as well. But the commonest places is in the introduction and in the discussion where you pick up errors. And again, plagiarism has an entire scope, like I discussed about misconduct. So it could be simple, small errors that you've copied a paragraph where it will be picked up, you'll have to correct it, but it's relatively minor, to people publishing an entire paper from somebody else in their own name, or having the entire paper being written by somebody else. So again, the scope, like anything else in misconduct, goes from minor to extreme, and your punishments would also change depending on how senior an author you are, or how much it is expected that you should know what is right and wrong. So if you're a junior resident writing his first paper, most editors would be far more benevolent than if you are a professor with 40 papers down your pocket and saying, I still don't know what plagiarism is. So a lot of this judgment call is taken based on the extent of the problem and your expected experience. So the bottom line on plagiarism, just don't do it. Requires a little extra effort. Don't do the Control-C, Control-V. Don't copy paste. Read, think, write on your own, and you're likely to avoid plagiarism. Now, I'm going to skip a little bit of this because I'm not focusing on it and I want to finish on time. So the last one aspect of misconduct that I'm going to talk about is simply submission misconduct. And this is again something which not many people realize is a problem. Let's assume that you are now an assistant professor, you're getting promoted to an associate professor. You need 2 papers, you've got only one and you need one more. Now, everybody knows that journals reject at least 60% of the time, and they take 6 to 8 weeks to give you a rejection. So you submit once, wait for 8 weeks, the paper comes back rejected, submit to another, wait for 8 weeks, and you'll end up spending 6 months before your paper gets published. I don't have 6 months. So why can't I submit to 4 journals at the same time? And the first one who gives me an acceptance, I will withdraw from everybody else. So I'm honest, I will not let the paper be published twice. I won't allow a duplicate publication. I know that is wrong. I just submit to 4. The minute I get an acceptance from anyone, I will withdraw from the others. So I don't get multiple publications. So is that a problem? Well, of course it's a problem. You can't do that. You can't be submitting to more than one journal at a time. And if you go back and look at every journal's website, when you submit a journal, they make you tick mark a box which says that we haven't submitted it anywhere else. So that's an important submission misconduct. We unfortunately still come across it very frequently, that people send us letters for withdrawals after about 6 weeks of submission. We will invariably keep an eye on such papers and see when they get published somewhere else. And if we find that it was submitted simultaneously, we will raise a question to that author. The other issues of submissions is that there must, of course, be author consent. Don't change your data after you've submitted unless there are errors that the reviewers have pointed out, which you correct. But otherwise, don't manipulate data. And again, like I said a little earlier about conflicts, it's not a very common thing to have conflicts. Particularly in India, I find it very uncommon that an author actually has a conflict of interest. But if you do have one, you must declare it. And this is the last slide. These are pictures which have been picked up from just last year, and we talked about COVID and how papers influenced practice. And unfortunately, at least 5 or 6 of these people are of Indian origin, who published large amounts of data. This was, I think, the Lancet, which carried some of this work, or was it the JAMA or the Lancet? I try to forget. The New England Journal has shown one retraction, which was papers which were retracted because the data never existed. And now these people are notorious. And unlike Bollywood, notoriety is not the equal thing to fame. You still have to have fame in research, not notoriety. And there are now punishments, both from withdrawals and sanctions. So thank you once again for the opportunity to be here and present. And I look forward to listening to the rest of the speakers. Thank you very much.
President, you're with us? Right. Dr. Rajiv, I think you touched upon the most contentious issues of today's session. I have one question on the DocPlexus platform. I think this can be addressed over the course of the meeting also, but having got the question, I would like to take at this point of time. He is Dr. Avatish Pandey. What he's asking is the content, the way of writing. Are they both dependent on the number of authors who are listed in the list of authors? That is his concern.
I'm sorry, I didn't quite even understand that question. So content, depending on the number.
I think he's telling, you highlighted the responsibilities. Who does the writing part? Who does the study part? Who does the funding part? Who does the data part? So he's trying to get an answer from you. Who gets the priority? The person who does the research, or person who writes or compiles the data and puts in a publication form, the writing part of it?
Okay. So typically the first author is the person who writes the paper. And by all convention, he should also be the person who's actually done the research, because he's the person who knows the most about the research. So let's assume that we're talking about thesis. That's the most common place where we have multiple people involved. If you've given a thesis to a resident, he's the one who's supposed to have done the bulk of the thesis, and he's also expected to be the one to write the paper. Therefore, he should be the first author. On the other hand, if you're a faculty group of, let's say, 10 doctors, 10 consultants working in a hospital, you decide to pool your experience together and write a paper. Let's say I'm looking at a private practice setup. The person who says that let's get together and look at our data is expected to be the one who will collect that data, and is also expected to be the one who will do the first draft. Therefore, he should be the first author. So it's not very difficult to define who will be the first author. In almost every case, it's reasonably clear. The person who's done The writing is also the person who's done the bulk of the data collection work and therefore should be the first author.
Point is taken, sir. Now, moving on to the next issue, you did mention about the financial support and other things. Many times when you are taking up original research work or funded research work, the principal investigator obviously remains one of the senior professor or head of the department for known reasons of management of funds and documentation and other things. Because all of us know the residents stay with us for 3 years, or unless it's a junior faculty who's expected to stay for a longer time. What exactly is the student's responsibility in this era? Does the co-PI and the PI always become part of the authorship, or it is fine if we are going to document it? He was the principal investigator for this study. What is your take on it?
Okay, so again, a good question. First, let's look at first the thesis aspect of it. If you've got a funded research, obviously you must be faculty to have got the funded research in your name, and you must have had some co-PIs with you. And you may have also given it as a part of a thesis to a student. Now, when your funded research is expected to last, let's say 4 to 5 years, it is not going to be one student who is going to do the entire part of research. But if you've given a part of it as a thesis, the thesis in itself will have to be a complete research project. You can't expect to be running a randomized controlled trial for 5 years, but you've given a student to work on it for only 2 years as his thesis. What is he going to get at the end of the 2 years then, if your accrual of patients is supposed to be 4 years? So if you're expecting to run a long-standing funded research, which will last more than the lifetime of a student, the student's thesis obviously has to be complete in itself, which may be a subset of your overall research. In which case, the student should be writing up his thesis part of it as the first author, and you will, of course, be senior author on it. When your entire research is completed and you want to write the entire thing as one paper, and obviously there should not be a salami publication. You can't end up saying that I'm going to collect 200 subjects, but this student can write the first 50 of them and I'll write the total 200. That's called a salami publication. That's not acceptable. So we are assuming that your overall research is bigger, but this student was given a small part. Let's say the student was made to look at one biochemical marker, but your research is looking at 40 different parameters. Then when you're writing up the 40 different parameters as one whole paper, and you as the PI are doing the writing, you have a right to be the first author and the corresponding author. Now, in terms of co-PIs as being co-authors, when a thesis is being written up for publication, it is not essential to have every co-guide as a co-author on the paper. It is not essential. Many times the co-guides do not contribute at all to the research. They were brought in the beginning with the hope that they would contribute, but they don't actually contribute. They don't even look at the thesis. In which case, if the contribution doesn't exist, they do not deserve to be authors, neither on the thesis nor on the research project. However, this is rare. If somebody has been brought on as a co-PI on a research project, particularly on an extramurally funded research project, it is very unlikely that they haven't contributed at all. And in which case, they should be given an opportunity to be an author on the paper.
I get your point, sir. Thank you very much. Now, I think I have a couple of minutes time left for questions. Could I invite Dr. Anil and Dr. Aman to share their viewpoints or questions or comments on this talk before we move on to the next talk, sir?
I think if Dr. Anil is not, Dr. Anil, please go ahead.
Yeah. Well, thank you, Dr. Rajiv Kumar. That was an excellent talk. You know, there were so many issues that were in fact cleared for well, several of us, you know, listening to you. And what I particularly liked about your talk, Rajiv, was the fact that you touched on the most relevant and the most important issues that we all face today when it comes to writing and publication. You know, starting with the authorship and then plagiarism. You know, these are things that are so important, particularly for our junior set of surgeons who are just venturing out into medical writing. And it is absolutely vital that these concepts should be made very clear to our young researchers. There are certain red lines that can just never be crossed. And that was, I think, the message from Dr. Rajiv Kumar, that there are certain red lines that need to be respected for research from our country to be taken much more seriously. And for that, we need to, I think, build up a strong base of young researchers who have their facts right. So, well, thank you very much, Dr. Rajiv Kumar. That's all that comes to my mind at the moment.
Thank you.
Thank you, Dr. Anil. Now I have the honor of requesting Rajiv sir to stay with us till the end of the program and share your viewpoints on the remaining talks and potential questions which may come up as well.
I'll try my best. I may need.
I understand, sir. I understand your value of the time. Now I have the honor of inviting our immediate past president, our mentor and well-wisher, and Dr. Aman Goel. Dr. Aman Goel is an eminent bariatric surgeon. He is the head and the director of the bariatric and metabolic surgery at the Wakhat Group of Hospitals, Mumbai. And he is the chief editor of the Journal of Bariatric Surgery, associate editor of the Journal of Minimal Access Surgery. And he also has important academic commitments. He serves as the member of the Specialist Board of the National Board of Medical Sciences for the Government of India. And he's the co-chair for the SAGES 2021. And he also takes care of the program directorship of the IMAS for the bariatric section. And he is the member of the Bariatric Metabolic Committee of the SAGES for the year 21 and 23. And he's member of the Ethics Committee for the SAGES for the year 2021-23. And he also serves the chairman of the Scientific Committee for the World Congress, which is one of the flagship events expected for the IAGES for the year 2024. And ladies and gentlemen, now I would like to invite Dr. Aman Goel to talk about how and why to publish. May I have the honor of inviting Dr. Aman Goel. Over to you, sir.
Thank you. Thank you, Dr. Kanagwil. I would also make a brief correction. Chief editor of Journal of Bariatric Surgery is Dr. Pradeep Chave. I am the editor of that journal. And thank you, Dr. Sunil Popat, President IAGES, and Sandeep for inviting me to this program. I think Dr. Rajiv has laid the foundation of this by starting with an important topic. I'm going to talk about how to do research and why publish. And the reason why this topic is close to my heart is that I find so many senior surgeons across the country whom I have met in last opportunity to meet in last few years, who say that they want to be a part of research community, they want to start research, but they don't know how to start and how to take it forward. So these are the guys who are having 20, 30 years of clinical experience, and they are struggling because this is one topic which is hardly taught in medical colleges. So I'll start my presentation. Let's hope this works. Yep. So how to start research and why publish? And both are interrelated because many surgeons feel that they are doing pretty well in their practice, in their life. And why should they spend so much time and energy on research and publications when it is no more required? They are already senior, they have grown up children. Or youngsters who know that research is important and they don't know how to start and where to start beyond the thesis. So for this presentation, I have no disclosure. So friends, the Cambridge Dictionary explains research as something where you want to do detailed study of a subject to discover information which could be new or reach new understanding. But if we go with this kind of definition, what we believe, what many start believing, that this means just being inquisitive or just questioning a practice. So if your senior is doing a kind of surgery and you believe that this can be improved upon, that is a research. Or if you are reading a book or reading a journal to understand some topic, that's a research. Modifying a technique or practice during your clinical work, is that a research? Discussing with peers outcomes of any modification that you have done, is that also a research? And accepting your limitations publicly or in private, is that a research? So yes, most of them can fall in the category of research because this is what ultimately researchers do. But research is much more beyond this. Of course, this is all required to have a researcher's attitude. A famous researcher and publisher said, research is a process of steps used to collect and analyze information to increase our understanding of a topic or issue. So research is basically your inquisitiveness, which is systematized, which comes in a system, in a process of steps, so that this is replicable, so that this is understandable, and this increases your information, your knowledge, and you share that knowledge with other people in the society. So research steps are when you pose a question, you say, is it true? Can this be improved? And then you collect data to answer the question. And then you present the answer to the question to the society. So you think of something which need not be, groundbreaking. It could be something very simple as doing a subtotal cholecystectomy, and what are the outcomes of this? And then you read literature about that, and what are the outcomes of subtotal cholecystectomy which are published. And you may find that you are doing something different which can improve the outcomes, and you can publish your outcomes, so that if they are acceptable to the society, that becomes a standard of care. So this is the way that you organize your thought process to be called a research. Now, before we go on to how to conduct the research, let's just briefly see what are the type of studies. They are grossly into surveys, which are like cross-sectional studies that at a particular moment of time, you analyze the society or you analyze the patients for a particular reason. Like you can say how many patients in the hospital, in a particular hospital have COVID at the moment, or how many patients in 10 hospitals have COVID at the moment, and then you can come out that 20% or 5% of the patients in hospitalized patients are COVID positive. So these are surveys. They can apply for anything in surgery as well. A new research protocols or new research technique that is evolving is collaborative research, where a large number of surgeons are coming together across geographic area to collect data and to publish it. Typically, collaborative researches are done where the patient numbers are small in any surgeon or surgical team's hands. So if I want to publish the mortality of bariatric surgery, which is let's say about 0.05%, or I need to have that many patients to be able to establish that what is the mortality. But if I get 100 surgeons to contribute their data, or 1,000 surgeons to contribute their data, it's much easier to reach out to a figure of mortality in a bariatric surgery. Most of these collaborative research could be cross-sectional or they could be prospective, and that is how you are able to find out outcomes where the numbers or where the incidences are less. Then there are cohort studies, which are typically prospective studies where a large population is followed for a long term. And these studies are important because they are generally more generalizable. That means they are more applicable to the society. And these are usually done by the department or institutions where they have access to long-term follow-up of patients. Then come case control studies, where you are having limited number of patients in each group, one group or two groups, and they are usually compared to each other. So these could be, like, you can say, patients who have acute cholecystitis and chronic cholecystitis. It could be patients who are BMI 40 and below and BMI 40 and above for bariatric surgery, and we look at their morbidity and mortality in long term. It could be retrospective also, because you already have the data of these patient sets. You just need to say what are the outcomes in male patients versus female patients after bariatric surgery, and this can constitute a case control study. The highest level of evidence in study is with randomized control trials, where generally the patient is blinded as to what kind of treatment that is being offered to them. There is usually a placebo. So in surgical terms, it could be a sham surgery versus a surgery which you want to see how it works. And then a good randomized control trial is double blinded. That means the person who is doing the intervention, which could be a surgeon or a physician, himself is not aware why this surgery was offered to this patient. So though, of course, the surgeon will be doing the surgery, but the patient is drawn by a lottery so that there is no bias. Bias is something which affects outcome of a study, and that should be avoided. So randomized control trial, if properly done, avoids bias of any kind, and that is why they are considered a very high level of evidence for or a good study. Then there's systemic reviews and meta-analysis, where you review the literature, and there are very definite guidelines. So I think it's a good idea for surgeons to start with case control studies or collaborative research, where they get to see their seniors doing the collaborative research, and they get to learn the kind of steps that are required in doing the research or in writing an article or publishing the article. So these are broadly the type of studies that we are going to talk. How do we proceed for research? And there are so many steps. I can speak for the whole day, but I'm going to talk on few of them which are important today. I think the most important one is the research question, where your curiosity is what works. When you question your senior, why do you do this way and why it can't be done the other way? So curiosity or towards a senior surgeon's technique, curiosity about a guideline, curiosity about anything related to surgery is where it works. And this is where your interest is important, and also the capability of the surgeon is important. Obviously, if you have never done a Whipple surgery and you want to do a research on Whipples, it is not valid. So you need, your capabilities are important. Everybody's capabilities are important, and that is when you decide what question you should ask. Research question is basically how to decide the topic of the research or the theme of the research. This should be very accurate and precise. You cannot have a general research question. You cannot say, how are the patients going to do in next 3 years after lap cholecystectomy? You need to have a very precise question, and which should be accurate so that the answer is also definite. And the purpose of research questions are basically two. Where and what kind of research are you going to do? So if you are working in a particular kind of hospital, you need to decide, does it have the facility to do this kind of research? And what kind of research? I already mentioned the types of research that you can do. And to identify the specific objective the result will address. Research is not just to get promoted. Research is not just to get your thesis completed. Every research, whether it's thesis or whether a publication for promotion or otherwise, must have an objective, because you are spending time and energy. This answer of your research should be contributing to the society, should improve the science, and that is how the research question should be designed. Now there are basically two types of design methods of a research question. The thinner one, the thinner is which is mostly for the feasibility of a research. And so the F stands for feasible, that do you have enough number of patients or subjects for the research purpose. So suppose you are doing only 5 bariatric surgeries in a year, and you have kept the number of the subjects at 200, you will probably take that many years to complete a research. So you should have adequate subjects, you should have an adequate expertise, and it should be affordable in terms of time and money. I mean, obviously you cannot have a research project going for 20 years if it is just finding the morbidity. Then it should be interesting to you, because if it is not interesting to you, you will ultimately drop it over time. It should be interesting to your peers, that means to other surgeons, if you're talking to surgeons today. And it should be of use to the community, because if it is of no use to community at large, then research will not become applicable. So then N stands for novel. It should be something new or different. It refutes or extends previous findings. So either most of the things have been researched. Most of them have been researched. When you do a research, the very word says research. You are trying to either confirm what has been found earlier, or you are refuting it, or you are extending it by adding to the knowledge. Research should be ethical, because if it is not there, then most likely your ethical committee will not approve it. And it should be relevant to science, clinical practice, policy, or future research. So this was published in 2007. And then there is something more which is applicable, which is called a picot, which is more applicable to surgeons, where you have a patient or a problem, a particular disease, and then you decide the intervention, whether you are going to do a surgery or you're going to use a new device or an indication that changes, and you need to have a comparison group. So whom are you comparing it with? Because always a publication looks good if you are comparing it, because if you're having only one set, then you don't know how the other group will work. So if I say weight loss after bariatric surgery in 3 years, I should have a control group which is being managed on lifestyle intervention, and then only I can say that bariatric surgery works better than lifestyle intervention. And then we should have the outcomes, and we should have the time. So I think these are two, and they are not one or the other. Both are important to decide a research question. The next step to find out a research question is to research the research question. That means you read published literature and you make extensive notes from there. So you read as much as is possible, or as much as is published on the topic that you want to research on, because this way you will know what exactly has been published, how it has been researched in the past, so you know the methodology adopted by the previous researchers, and you know their outcomes. And by knowing all this, you can assess the feasibility, whether you will be able to do this research or whether you will not be able to do it. And then it's a good idea that you come out with an answer to your research question. You should think what you are going to get the answer. You may be proved wrong, or you may be proved right. That is a different thing. But research question is something which, and answer to the research question is equally important. Once you have identified a research question, then you need to design a hypothesis. Now, what is a hypothesis? Hypothesis is basically a testable statement. So you make a statement that what do you predict? Suppose you make a statement that I believe after subtotal cholecystectomy, 20% patients will develop gallstones again within 10 years or after 10 years. So now you need to do this and make a hypothesis on this, and then you will have to see whether your hypothesis works at the end of the research study. Hypothesis should be made at the start of the study. It is not something only to write in your thesis. Or in your research publication. It should be done right at the beginning. And this is usually to propose a relationship between two variables. Now, what are these two variables? Variable is what new you are going to do. If you're going to do an intervention, what intervention are you going to do? This is an independent variable. And the dependent variable is what will come out of it. What will the research measure? So suppose you are measuring the percentage of gallstones after subtotal cholecystectomy. That is a dependent variable. So when you do a subtotal cholecystectomy, this is an independent variable, and what comes out of it is dependent variable. And whether they match, whether the independent variable has an impact on the dependent variable is what is a hypothesis. Now, friends, hypotheses are basically of two types. It could be alternative hypothesis and null hypothesis. Now, alternative hypothesis is, in simple terms, that there is a relationship between two variables being studied. That means, if we continue with our example, that means if I do subtotal cholecystectomy on my patients, then I believe 20% of them will develop gallstones after 10 years. That means one variable has an effect on the other, because in total cholecystectomy, it doesn't happen. So this is what is an alternate hypothesis, that you are correlating one variable to another. And that these results are not due to chance, and they are significant to support the theory. So that means this is not just an incidental thing. This is because I did a subtotal cholecystectomy. That's why I got the gallstones in these patients later on. The other hypothesis is null hypothesis, which says that there is no relationship between the two variables. So null hypothesis is that if I do subtotal cholecystectomy, patients will not have gallstones in long run. So this is null hypothesis, that there will be no impact on the incidence of gallstones after 10 years. This is null hypothesis. And thus these results are not due to chance, and they are not supporting the idea that the gallstones will form after a cholecystectomy, subtotal cholecystectomy. Now, it's important to realize that can a hypothesis be proven? Now, as a researcher, please understand, and when you're going to write a paper, alternate hypothesis can be rejected or supported, but it can never be proven to be correct. Never try to say that because your hypothesis has been accepted, that means this was the reason for gallstone formation. There may be something else. So results should not be projected as proving a theory, because when you say the results are proving a theory, that means it is giving 100% certainty. But it is possible that the evidence to contrary may be already existing, because there are many things that you may be doing different than what other surgeons have done in past. And so alternative theory can only be rejected or supported, but don't say that this is correct or this is proven to be correct. While the null hypothesis can be accepted or rejected, because you can say that I said that the gallstones will not happen, and this is true, that I accept my results show that my hypothesis has been accepted. Or if gallstones start happening, then you can say that my null hypothesis has been rejected. So it's important that when we are writing a paper, after the thing, we keep this in mind. And there's nothing wrong about a hypothesis which has been proven wrong. We recently did a study in 2020 about use of zinc in COVID patients. And why I as a surgeon did it, because my physicians and intensivists were extremely busy, and we analyzed the data, we did the study, and we have published it recently to say that zinc hypersupplementation does not reduce hospitalization or mortality in COVID-19 patients. So though we thought that this will come out, hypothesis said that this will reduce serious hospitalization or mortality, our hypothesis was proven wrong, and thus still we published it. And so that is about the hypothesis part. Now, an important component of starting a research is a sample size. Now, sample size is basically number of individuals to be included in a study to represent a population. This is very important. If you are looking at a population of 1 crore, how many persons you should test your intervention to prove that when it is applied on the whole society, the results will be same. So appropriate sample size is important for proper analysis. When you have a small sample size, it doesn't represent the entire population. When you have a large sample size, it definitely is more representative, but it may result in high cost, it may have a problem in logistics, and it may have a problem in research time. So you must have an adequate sample size, and sample size is something which I'm going to talk briefly today in detail today. So if there are few important definitions when you are looking at sample size. One is a confidence interval. So what is confidence interval? It is generally shown in plus and minus. It shows how confident one is that the results from the study would be similar if it were possible to survey the entire population. So now this confidence interval, which should usually be 5 or less, but it can be more depending on your research approach. So that means if 100 people are tested, the results will not change more than 5% in those 100 people. Or if the entire population is tested, the results will not vary more than 5%. So this is important, confidence interval, and this will help you decide the sample size. You can decide what will be the confidence interval of your study. You can keep it 20 or you can keep it 10, but a good study should be around 5, and that is what your target should be. Then confidence level. Confidence level shows how often the percentage of the population will pick an answer within the confidence interval. So if you are keeping a confidence interval of 5, that means what is your confidence in your study? That most of the people will pick up the answer within these 5. Now, it is a good idea again to keep confidence level at 95%. But even if you keep it 90 or 80, you can still publish it. But then the results will be taken with a pinch of salt, because I will be looking at studies which have a high confidence level and low confidence interval. That means the error in the study is more representative. So larger the sample size, higher the confidence level, and smaller the confidence interval is what we target when we are trying to decide a sample size. Now, so when we determine a sample size, we need to know the population size, we need to decide the confidence interval, we need to decide the confidence level, and we need to decide the standard deviation. Most of you know what is standard deviation. And if we know this, then as far as confidence level is concerned, we calculate Z score, and which is actually a defined score. So if you are looking at 95%, it will be 1.96. And then you can apply it in a formula. Now, sample size calculation is Z score square into standard deviation into 1 minus standard deviation divided by confidence interval square. Or if you don't want to do it yourself, you can go online and put up all these details in this particular formula, and this can give you a calculation right there. But a simpler way is that if you are looking at a confidence level of 95% with 5% margin of error or confidence interval, most of the time for any population size, 400 to 500 is a good sample size. It could be less, so you need to calculate, but most of the time 400 to 500 is a good sample size, which is usually acceptable. Now, once this is done, once you have done the sample size estimation, you can write down your study protocol. This is the time when you should write down a study protocol. It's a detailed protocol, but let me highlight few things. You must write all steps and documents used during the study. That means where from you got the literature review, what you did, how did you design it, everything. Hiding something in your study, in your protocol is not desirable, rather it's looked down, because the idea of research is that what you are doing, some other surgeon should be able to replicate just by reading your protocol. So protocol should be very elaborate, because research is only validated when other surgeon is able to, or other researcher is able to replicate what you have done and comes out with similar results or different results. So protocol is very important. Focus on primary research questions. So generally we find that in a publication, the author is trying to answer too many things. It's always better to keep your research simple and specific. Have one endpoint, primary endpoint, one question that you answer. And then during the process, you may have few more secondary endpoints, but those secondary endpoints or secondary questions should be different from primary questions and they should be distinct. So it's very important that a study protocol is written by you and then seen by an experienced person so that the errors are limited. Because if you make an error at this time, it will have an implication for long terms when you go for publication. Then comes, how do you record data? There are various ways. There are simpler ways. Most of us are using Excel sheet nowadays. You can use Google Sheets if there are multiple people involved, because then it's easier to enter data from various sources. Or you can use a SurveyMonkey kind of platform to collect data if you're doing a survey or a cross-sectional study. Then there are custom designed softwares. So you can, if you have the funds available, you can get a software designed for your study, but they cost a significant amount and you can take a call. And there are standard platforms like RedCap and many others, which are pretty expensive, but depends on your funding sources. You can use one of these, which gives you a level of comfort, but are pretty expensive. And though I have participated in some of the studies, I have never used them on my own. It's a good idea that when you are defining the parameters, this is a very important step. What you do, what you collect at the beginning should be decided based on what are you looking at as an outcome. Because many times I have seen people collecting data, and then when they start analyzing the data, they realize that they have missed out on two important parameters. So it's a good idea to involve a statistician at this stage, so that what you are collecting should be comprehensive and specific to the study. Don't just collect because you have an opportunity to collect everything, but make it very, very simple. Once you have written a protocol, once you are set to start a research, always go to the ethical committee. Now, your hospital or institution may have its own ethical committee. Go to them, get an approval. If it is not there, if you're working in a smaller organization, they are independent ethical committees. And that it's a good idea or a mandatory idea to register it with Clinical Trial Registry of India. It's a portal. It's quite simple. You enter the data and you get a clinical CTRI registration number, because many of the journals insist on trial registry before they publish, and it brings credibility to you. Funding in India is usually not availed by most, because except by the institutions. Most of the funding is given for equipment, software, or assistants, clinical researchers. Funding could be from institutions like these, like CSIR, Department of Biotechnology, or ICMR, or by corporate. But funding means it takes time. So if you are looking for a research, the whole process of getting the funding can extend from 6 months to a year, just getting the funding. So if you really require the funds, then go for it. Otherwise, you can give it a go by. Then data collection should be time bound. It should be honest. It should be complete, and it should be as per sample size. So I move on because I know there are two more speakers after me. Data analysis is usually done in conjunction with the statistician, but my personal experience is that you should try to do it yourself first, so that you learn how to analyze the data, and then you involve the statistician who can find out where you've gone wrong and rectify it, so that in next study you know what to look for. And this is the time when relationship between variables, as I mentioned, is interpreted and significance is established, and the information that you have collected is transformed into the work. So information is something which transforms into knowledge at this stage. Now, coming to the end of my study, my presentation, why to publish? We know so many people write blogs nowadays, which is so much simpler to do. But blogs doesn't have a peer review. You can write whatever you want to write. There is nobody. I mean, you may have few people questioning your judgment, but there is no peer review. and the blocks are lost in eternity. It's very difficult to recollect a block. A peer review process goes through a scientific rigor for your research. This becomes a credible, searchable record. I know with Google you can search a block, but when you're searching for, let's say, a subtotal cholecystectomy, if you have published your results, it will always appear there. And own research, when you do a research, it's a source of learning for yourself, and you need to realize need to learn is a long-term thing. Why should a young surgeon publish? When a young surgeon, somebody who's doing his post-graduation or after post-graduation, it helps him learn a particular thing in detail. Obviously, he has been taught during his post-graduation, but what he learns when he tries to publish something is beyond comprehension if you have never done a research. A young person may come out with novel thoughts which may have been missed by seniors, and he may come out with some groundbreaking research which has not been done in past. And for a young person, if you publish, it helps early talent recognition. It improves your employability, and it helps you get invitation from conferences. So I'm in IAGES for a long time. People come and ask why we don't get invited to conferences. Obviously, people who are well known, they are invited. But if you are publishing your work, people know that you are an authority, and you automatically get invited. Why should senior people publish their research? Because they get new challenges which are beyond surgery. You do the same kind of surgeries every day. I believe every patient is different. I agree with that. But this is a new kind of challenge. It showcases your thought leadership, because now you are thinking in new areas, and you are able to show what you have thought in the last 20, 30 years, whatever you learned. It helps others learn from your mistakes and your learnings. And friends, this is time to pay back, because it helps in growth of science, because we have learned the same way, and now we are paying back to the society. Just to show you, in this 2021, though the clinical work was less, we had about these many publications, some of them collaborative work. This one is the zinc study. This is a bariatric study, and the guideline publications, and these kind of publications go on. This is one of the collaborative work that I'm doing, my team is doing, where we have about 150 surgeons from 46 countries participating, because revisional bariatric surgery, how the outcomes can be audited. Every surgeon is doing, let's say, 5 to 10 surgeries a year. So it's very difficult to audit their outcomes. But when we are collecting data from 150 surgeons, it brings in a pool of data, and that helps. So to conclude, I think research is a humbling experience, because you go in an area of uncharted territory, and you learn from people who have worked before you and who are working with you across the world. So thank you so much, IAGES, for inviting me for this presentation, and I'll be very happy to answer questions at the end.
Thank you, Dr. Aman. Before I move on to the President's comments, I have a quick question from the DocPlexus platform. There is a participant delegate, Dr. Tejas Shinde. He has asked us, the usage of tools like R program is often visible in highly cited research papers. Sir, how to go about using such newer tools for biostatistics? If possible, kindly recommend good text to acquainted to these type of most recent tools. Thank you very much.
Okay. So, Kanagvel, I'll be very honest to show my ignorance. We always use statisticians, because being a practicing surgeon for almost 35 years, I got into research in last 8 years. We go through the statistician route to involve them in this, and I'll be very happy if Dr. Sandeep or other panelists will answer this question.
No, I think excellent talk, Dr. Raman, very comprehensive. I think that what you said is right, Maul. Most of the surgeons are really don't have an extensive knowledge of statistics. So we do take the help of statistician in all the major research papers, and there are a lot of softwares which are available for statistical analysis. And I'm really not aware of which one is the best. But I think involving a statistician is a good idea in research, because we can do as much as we know. We can't learn everything. We can't know everything.
Thank you, Raman. Excellent talk. Really enjoyed.
Thank you.
And you brought out all the very important points for a young researcher, how to start the research. And I'm sure many young surgeons are getting inspired by listening to these talks on research. And I'm in next 5 to 10 years, we'll have many more surgeons, particularly if we talk about surgeons, many more surgeons coming out with their own research and publishing from India. So thank you very much. Yes, Anil, you were saying something.
No, not really. I think Sandeep had answered that question as far as statistics is concerned. Though I do not use the net very much as far as statistics is concerned. We, belonging to the old school of those who in fact consult with their statisticians. That is how we do it as well. But my impression is that there is no one-stop, statistical site that will provide answers to all your questions. So you have to be active. You have to, search actively for what exactly you want on the net, but not much more to add in this subject.
Yes.
President, sir, can we move on to the next topic, sir?
Yes, please, Kanag.
Yes, sir. Thank you very much, Dr. Raman, sir, and thank you very much, Dr. Anil, sir, for your comments. A quick word on R software. It is a freely available software. It is a very effective data handling and storage facility which gives many flexibilities for the editor. And the R platform is freely available for the participants, and there are fixed curriculums and teaching programs for the researchers also. So I would request all of you who are interested in learning about this can visit this website. Thank you very much. Now I have the honor of inviting Dr. Anil Sharma. Dr. Anil Sharma is an eminent minimal access metabolic and bariatric surgeon from the Max Hospital, New Delhi. And he is one of the world-renowned eminent herniologists. And he has been the president and the founding member of the APHS. And he has had a phenomenal way of training from Mumbai to Delhi. And he has been involved in academic teaching in the IAGES and out of IAGES for many years. And their minimal invasive teaching program from the Max Hospital is a very coveted program and very respected program over the past 3 decades. And he himself, at various positions of the editorial board of the JMAS, have ascended and have set very high standards for the publication and the content of publication in the JMAS. Now, ladies and gentlemen, we have the important part of it. How to do a research, what are the content of authorship, everything having discussed. But then sir is going to address us how to do an effective medical writing. Can I have the honor of inviting Dr. Anil Sharma? Over to you, sir.
Yeah, thank you, Dr. Goel. We know for a fact that that you have been instrumental, in pushing forward the academic agenda of the IAGES, along with our secretary, Dr. Iswar Murthy, and led by our presidents, the past president, Dr. Aman Goel, and the current president, Professor Sunil Popat, Dr. Sunil Popat, both of whom have been so active during such a difficult time that we have all gone through. And, it is really credit to all of you that we have started talking about basic medical writing now. And I remember Dr. Sunil Popat has been especially persuasive to all of us to try and push to have programs like these online so that more and more of our young surgeons can sort of get some help from these programs. So what I'm going to do is that I'm going to share a talk that we had created only for the IAGES a few months ago, and that is on basic medical writing. That is about 30 minutes, but I think I will cut it down in the middle to about 20 odd minutes so that we can hear Professor Sandeep Agarwal also. So let me try and get to our to my presentation if I can.
Do you have any challenges, sir? Are you okay?
While it is playing at my end, I'm not sure it's playing at your end, is it?
We are unable to see you, sir. See your presentation. We are able to see your video. Okay, maybe you have to stop sharing your video and restart sharing your desktop, sir.
Okay. So stop sharing my video.
There is a share screen button, if you can see it over there. So if you can press that.
Yeah, I did that, but right. So what I suggest is, can we have Professor Sandeep Agarwal speaking first while I try and sort out this issue on my side so that we save time?
Dr. Sandeep Agarwal, are you fine with that, sir?
Yeah, I'm okay. I'm okay, fine with that.
Right, sir. With the permission of the President, now I welcome Dr. Sandeep Agarwal. Dr. Sandeep Agarwal is a eminent bariatric surgeon. He is a professor in the Department of Surgical Disciplines of the All India Institute of Medical Sciences at New Delhi. He is the editor of the JMAS, and he also works as a member of the editorial board of the obesity surgery. He has special interest in bariatric surgery, renal transplant, and he has a brilliant academic career, which started from All India Institute of Medical Sciences. He has spent time in the United Kingdom, United States, and later he has been actively participating in many academic activities on various surgical scientific societies. And is the founder president for the Foundation for Obesity Research and Metabolic Surgery. And he is a past executive member of the OSSI. And to his credit, he is been on teaching and operating faculty of various central and state institutes. And he is also part of the active academics of the Indian Association of Gastrointestinal Endoscopic Surgeons. Ladies and gentlemen, may I have the honor of inviting Professor Sandeep Agarwal on why do journals reject articles? This is the vexing thing, and everybody would like to look forward to hearing the wisdom of Professor Sandeep Agarwal. Over to you, Professor Sandeep.
Yeah, good evening, everyone. Am I audible?
Audible, sir. We are able to see your slides.
Yeah. So first of all, thank you, Dr. Kanagwel, for the introduction, and also thanks to Dr. Sunil Popat for giving me this opportunity to be a part of this important teaching activity of IAGES. And I also would like to thank at the same time my co-speakers, Dr. Rajiv, Kumar, and Dr. Aman Goel, and Dr. Anil Sharma, who kindly agreed to my request to be a part of this webinar, as they are such eminent editors of journals. So I thought they would be the right faculty for this webinar. So thank you once again. So I'll talk about why articles get rejected. I would also give my personal viewpoint on how we look at the articles and why do we reject at JMS. Meeting some aims. If you look at the 2019 data of JMS itself, you would realize that rejection is a norm, actually. So most articles get rejected, and only roughly about 20 to 25% articles get accepted in an average journal. I mean, for example, JMS, our acceptance rate is roughly 1 in 4 or 1 in 5 sometimes. So you must remember, first of all, that rejection is not something, a failure as such. It is that the journals get too many articles, and in spite of that, your article being very good, the article may get rejected because the journals is burdened with a lot of articles. So one should not get disappointed. So if you look at the manuscript submission to publication, when you submit a manuscript, it goes through a technical review, either by the managing editor or a person appointed by the editor, or sometimes by the editor themselves, where we look at whether the submission follows the guidelines of the journal, whether all the boxes have been ticked regarding the article type, the word count for a particular type, the plagiarism check, and overall, whether it conforms to the format of the journal. So that is the first step which occurs, and a lot of articles do get rejected at this stage. Sometimes when there are some changes required, we send them for technical revision. But a lot of times articles do get rejected, because of the errors there, and especially the plagiarism part, when we see it's a very high degree of plagiarism is there. Then comes the initial decision at the editorial level. So the initial decision could be again a rejection, as I said, when the article does not conform to the readership of the journal. It is beyond the scope of the journal sometimes, so the editor may get rejected at the outset. For example, a very basic science article may get rejected when in a surgical journal. There is not of interest to the readership of the journal. Then there are other reasons why they get rejected, or the decision could be the paper is sent for peer review. Once the editor sees that it is okay to go, it is suitable, then he will send it for peer review to 2 or 3 reviewers to get their opinion and to suggest any improvements in the article. And at that stage, again, based on the reviewers' comments, and that's the beauty of the peer review. It's not the editor's decision, there. It's the viewpoint of the referees, where you base your decision on their comments, and then the final decision is taken based on the comments of the referees there. Once it goes through a peer review, then it's again the reviewer's decision, reviewer's comments, which become of paramount importance, and the final decision is obviously taken by the editor, whether to accept it or to send it for revision, for minor revisions, for major revisions, and sometimes we send it for major revisions, but may still reject it, if the revisions are not satisfactory, or we reject it because of the reviewer's decision favors rejection. So roughly, as I said, the rejection rate can vary from various percent depending on the quality of the journal or the number of manuscripts received by the journal. So one of the important things not to get a technical rejection is to follow the author guidelines of the journal by the book. You should tick all the boxes, check There's no shortcuts there. You have to really follow the guidelines because then it shows that you are serious about your publication. And if you not follow the guidelines, that's just a very casual approach. So, as I said, a good number of submitted manuscripts have mistakes in one of the sections. Either they are submitted as a wrong type. There is an excessive word count, which is a fairly common phenomena. It is suspected plagiarism. Remember, we have tools to check plagiarism so we have really good tools with the editor where we check the plagiarism immediately. Each manuscript goes through a plagiarism check. Then duplicate submission or an incomplete submission. Sometimes the tables and figures are not there, which have been mentioned in the manuscript, or is totally unorganized manuscript of poor quality. And then there are lack of adherence to journal guidelines. Incomplete sections could be like title, authors, affiliations. I think most of the time it's the references which are incomplete. That is the most important part of, again, a manuscript. And if the references are incomplete, which again such a very casual approach to the manuscript writing. Again, look, figures which are incomplete. The legends are not, self-explanatory. All the figures and tables should be, standalone. So if one goes through a table or figure, it should be understood without going through the manuscript. So the legend has to be a very comprehensive legend. And again, as I said, references are the most common section, which is, sometimes full of mistakes. So this is a checklist from JMAS where, you have to tick all these boxes to, get to the technical stage of the article. And I won't go through for the lack of time. Plagiarism, as Dr. Rajiv has already talked about, again, I would not, go through it. Only a tip to you when you're writing. When you write a manuscript, you go through the various articles, the review of literature, read those articles, keep them down, and then write down in your own language. You can highlight certain points in the article so that you can come back to those points and, so that you don't miss a point, but close those articles, close those, PDFs, and then write from your memory. That would be the best way to avoid plagiarism, in my opinion. Self-plagiarism is again a form of plagiarism where you pick up content from a previous article. And so supposing your methods are same for two studies, write the second article and state that the methods have been discussed in a previous study and reference it, rather than repeating the same language again in the second article. So as I said, rejection at the editor level after the technical screening, that's the next step. That you have chosen a wrong journal, a very specialized surgical journal, you have chosen for a very common, let's say a hormonal study or a detailed, very basic science study. The work is not of interest to the readers, or you're aiming too high that your article, is not of a very high quality research, but you have opted for, very high impact journal. Or there's a clear cut, lack of any new message, especially true with case reports. What you think may be novel in your case report is actually not novel if you go through the literature and must have been reported many times. So, or the same manuscript or same topic has been published in a recent issue of the journal. Again, so editor is unlikely to publish that. So quality of the article, again, there's a flawed research question, and I'll elaborate all these points in a poorly written manuscript. So, if we look at this rejection from the editor, so what this combination of diet and bariatric surgery, and I'm not going to, this is an actual example in obese rats. How does it affect the hormonal something in obese rats? And they go on discussing the various mechanisms and the pathophysiology, the physiology and the biochemistry, which is too complex for an average surgeon to understand. So obviously stand rejected. This was again, another study where they discussed the MRI study to study obesity surgery-induced changes in the brain, pathways, and they went on and on in the paper to discuss the various types of MRI modes, and the whole paper was actually too complex to be understood by even the comprehension of a humble surgical reviewer. So obviously, we would reject it because even the reviewer or the expert is not able to understand that. So how can, reader be interested? Or let's say aiming too high. Sometimes we think our research is very high-fi, we have done really very high, and we aim for a high journal, like Anil or something. So although it's a good idea always to aim a bit high so that you get, even if it gets rejected, you get good comments, but sometimes aiming too high brings about disappointment. Okay, and this is again an example from one of our own submissions to Annals of Surgery. So when it comes to editorial rejection, the overall parameters, one of the most important things is poor overall quality. Once editor is so experienced, once you go through quickly, even through an article, you can realize it's an overall poor quality and cannot be improved even after reviewers' suggestions. There's a lack of originality. The similar articles have been reported in good number earlier. There's not even enough impact of that research. There's a lack of novelty. I think Dr. Raman discussed the final criteria where all these things were taken care of. So these criteria should be fulfilled. I think one of the most important reasons for rejection is a poor language and grammar. Although editor do understand that the English level of everybody is not same. We always give a space for that. We do not want to, but at least it should be readable. We do not, every sentence should not have some error. There can be some sort of language and grammar errors, which is understandable. You need not be like very, very proficient in English, but a reasonable level of English is required to write a good paper. Okay, so again, a sample size, technique, other things of, those also come as for editorial rejection. When we judge up at the editor level, is it within the scope of our journal? Okay, is it adding to the existing knowledge? Are the methods employed appropriate and sound? How was the sample size calculated? What were the statistical methods, the ethical concerns? And the writing is clear and easy to comprehend. I think the last parameter is very important, that is the writing clear and crisp so that, it's a pleasure reading it. Into one of the most important neglected parts is the cover letter. Sometimes we just write it, we are submitting this manuscript and just say a few formal lines. But you must remember that the cover letter is an important thing the editor looks at. It should convey a brief key aspects of the research and why this paper matches the aims and scope of the journal, and what are the novelty and future implications of the study. You must, briefly 2-3 lines say why this study could be useful for publication in the journal. So, and all other things which are required by the journal, like, non-submission to other journals, the conflict of interest and other things which are required in the cover letter. I think Dr. Rajiv talked about salami slicing. There's a recent report which shows scientific output is increasing every year by 8 to 9%. Is it the real growth of knowledge, or is it mainly due to salami slicing or splitting of research into several papers according to some experts? And obviously, salami slicing is a form of a misconduct, scientific misconduct. So it should be avoided. Again, one of the examples is if you have a large database of 1,000 cases, and then you divide, or you've done a study, and looking at and then you divide this into 3 papers, which could have been easily put in 1 paper, is not really a good thing to do. I want to go into this slide. It has been discussed. Again, these are the generally on an objective criteria to look at a manuscript by the editor. These are the 4 or 5 points, which is, just gives an idea how good manuscript is. So poor overall quality means most aspects are bad. Sometimes the results are okay, but the discussion is bad. Sometimes most of the sections are badly written, only the design is okay. So the study may have a good sample size and good research question, but the subsequent study design is inappropriate. Sometimes one tends to overanalyze the results. Once you have studied the feasibility, but you are talking about safety in the discussion. You have not really analyzed the safety, but you are talking about safety. Sometimes feasibility and safety are taken together. So these are things to be avoided. Poor language, and I'll just talk about a few examples on various aspects of faulty study design. Sometimes there's an unclear research question. The wrong population is included. There's a wrong control group or a comparative group. Methods which cannot be repeated. Sometimes they're so complex, which whenever one publishes a study, the method should be such that any other researchers can repeat it in their own setup. Inappropriate statistics, especially the sample size calculation. So if you look at this one example, again from a rejected manuscript, this large database, this paper on more than 3 lakh patients who underwent bariatric surgery, they reported that results of surgery are superior in patient NAFLD. And how could they come to this, incongruous result? We all know that NAFLD patient would have an inferior result in terms of bariatric surgery outcomes. But what they found was in their database was only 5% patient had NAFLD, while we know that in an obese population, 70% patients roughly have NAFLD. That means they're wrong. They use wrong diagnostic criteria for NAFLD. And hence their whole database was wrong. For the study population was wrong. And that led to erroneous results. So again, when you're designing a study, please look at these factors that the database you're taking has been defined correctly by proper objective criteria. In this paper, weight after bariatric surgery, this paper talked about revisional band surgery, which could have been a good paper had they compared with other revisional procedures. But they decided to compare with the primary gastric banding group, which we all know the primary gastric banding group would always have better results. So there's no point in saying that that primary gastric banding has better results than revisional surgery banding. So they did not take the correct comparative group. Faulty methods, wrong sample size calculation. Now, one of the commonest trick people use is to overestimate the complication incidence. So we all know that if the difference of complication incidence is large, you need a smaller sample size. For example, if I say leak rate after safe gastrectomy is 10% without oversewing and 1% after oversewing, so we need a small sample size to prove that. But if the difference is small, we need a huge sample size. And sometimes people, in the literature, they would only those articles which shows a large incidence of that complication. And this is really, again, not a good thing to do. And sometimes the sample size is calculated on a secondary outcome, while it should be calculated on primary outcome. So again, for calculation of sample size, you should follow the correct methodology and try to, avoid these tricks which are easily picked up by the editors, that this is, or the reviewers, that these are, the researchers trying to hoodwink the readers. I think, again, a poor presentation of data, the lack of proper figures or tables is common. Missing legends or incomplete legends, or repetition of data in the text and tables and figures. These are, again, poor examples of poor presentation of data. I think one of the main aspects of manuscript is discussion. One can easily write introduction and all from the study design you started with. But obviously, when you write a manuscript, you have to discuss your results, discuss the positive results, the negative results, and here what the people miss out. They sometimes repeat the introduction in the discussion. One of the commonest mistakes is to repeat introduction and results in the discussion. Discussion is not a repetition of introduction and results. It is basically stating what your most important result is, how is it different from the existing knowledge, what are the reasons for this difference, and you have to discuss each primary outcome, secondary outcomes. And this is what is the the new knowledge you're gaining out of the deeper understanding of the research comes from discussion. And obviously you have to take the most recent references here. Again, don't use, suppose you started a project 5 years back, okay, and you did a literature review that 5 years back. Now, when you write a manuscript, please again do a literature search so that you have latest references. Things change drastically, as I said. There's a lot of knowledge pouring in every day. So there'll be a lot of articles, a lot of new knowledge, and don't sort of use old references. Again, sometimes all relevant results are not discussed. As Dr. Rajiv said, sometimes the mortality is not discussed, which is important. Sometimes you say a procedure is good because it shows good weight, but you have not discussed the complications. The complication may be high. And always give a lack of explanation for any unexpected findings. Okay? Give a reference for any new thing you say, trying to say. References should be used, very nicely. You can't just make statements out of the blue, because science doesn't work like that. So you have to support your statements in the discussion by references. Always give strengths and limitations of study, because it's good to acknowledge it. I mean, if you say it's a small sample size because of these reasons, you say that. Or we did not use the liver biopsy in this study because of safety concerns. That's all right. So we always give limitations of a study. And always discussion again should have a very good flow. It should read like a story. Again, this portion, people made too many conclusions often not related to study results. While you might have discussed, just given weight loss, weight outcomes and the results, you might be discussing mortality, you might be discussing safety, which you have not studied. So conclusions should be based on your data and should not just say cliched things, and should not give wrong conclusions. I'll give you some examples. The impact of robotics, this is one example. Impact of robotics in learning RYGB. The authors mentioned 3 leaks and 5 bleeds. Just, we know that in RYGB complication rate is very low, but if you say 3 leaks and 5 bleeds, and one more in 80 cases, and then yet say robotic technique is safe, I think is really going too far, because this is a very high complication rate for 80 patients. Again, 3 out of 3 cases at bi-league using ICG during lab chole, while 5 patients at bi-league without use of ICG. So ICG is beneficial in increasing the bi-league rate. I mean, any common experienced surgeon can make out this is wrong conclusions. Again, there is another example, and all these are real examples. A large database outcome study showed from a nation, from a region in the world, our mortality rate of 0.9% in line with global standards. While in the discussion, they quote other studies with most having mortality rate of 0.1% or less. So if you quote studies which have a mortality rate of 0.1% or less, and your own mortality is 0.9%, how can you say that our results is safe, are as good as the global standards? So these contradictions should not be there. So all these things happen, very, very frequently, and experienced editors pick them up, or reviewers pick them up fairly easily. Sometimes unimportant results which are not clinically relevant. Sometimes the research is done just for the sake of research, mostly in thesis, and they may not mean anything to the practice of that specialty. And sometimes these would get rejected because they are not clinically relevant, although they would say something which could be obvious from the study, but they are not applicable in clinical practice. Many mistakes in references, improper tying of references, old references, providing wrong references is again a portion which is fairly neglected in a lot of manuscripts. So please do a reference check. There are softwares available, and we go with the references. Give the most recent and relevant citations, and avoid self-citation, which is also not taken very nicely by a lot of reviewers. I think most of the problems occur in RCTs. In surgical RCTs of poor quality, we always want to do an RCT because it's considered a high quality study, but we have to follow all the guidelines, have to have a good sample size. So when you are reporting on RCTs, follow the consort guidelines, because the editors look at that the RCT is done with proper guidelines, proper sample size calculation should have been mentioned, the blinding, the allocation to the various groups, and there are various criteria to look at the quality of the RCT. Case reports are again a section where a lot of rejections occur because what you consider novel is not really novel. Sometimes you give a study saying and you don't have the images. So for a case report, please have all the images or the histopathology. Without that, the case report is meaningless. I'll just go into my reasons for rejection. Normally, one of the most common things is too complicated for an average reader to comprehend for a surgeon. We are all surgeons. We all are doers. We have a limited knowledge of statistics and a lot of basic sciences. So we sometimes manuscripts heavy on these do get rejected in my hands. Study design, extremely poor English and grammar, too many repetitions, deliberate omission of facts or mispresentation of facts and literature, mismatch between results and interpretation, hence wrong conclusions, poorly written discussion with inadequate review of pertinent literature, omitting discussion of crucial results, poor clinical relevance, or a combination of one or more leading to overall poor quality. Now, one of the important when article gets rejected is there an editorial bias? Whenever we get this thing, I just always want good quality citable articles. So bias is almost none, believe me. I mean, and most of the review articles which are sent it to the reviewers are blinded. They do not know about the authors or the institutions. So there is a very little scope of bias actually, and may have some positive bias, as Dr. Rajiv said, for a well-established researcher. But if you have a name who's very reputed in research, sometimes you may have positive bias for them, but almost nobody wants to reject them. But we all know how much hard work it goes into writing an article, and it does depend on good reviewers comments, and in most good journals review process is blinded. So that's why the peer review journals, that's why they're good, when you have a peer review. So please check formatting, check for all the points I've talked about, references. But at the end of it, be honest. I think honesty, because everybody, as Dr. Rajiv said, we trust what is written in the article. So be honest with your research. Let the manuscript be judged based on scientific content and merit rather than avoidable mistakes. So all I talked about, there are a lot of mistakes which are avoidable, but if you make them, it may get unnecessarily rejected. So let it be judged on its positive part rather than by mistakes. So again, briefly, just a quick point: when articles rejected, do not get dejected. Do not think there's a bias. Try to improve your manuscript. Sometimes reviewers' comments are very pertinent. Plan for another journal, and go ahead and put your best foot forward and leave the rest to God. Thank you so much for your patient attention. Thank you.
Sunil sir.
Yeah, thank you, Sandeep. Excellent talk regarding how the literature, the papers gets rejected from the reputed journals, and you brought out excellent points. How not your article to be get rejected. I also thank Sandeep for combining and putting forward all these eminent faculties here on this board. I'm pleased to share with you that more than 600 delegates are listening to tonight's webinar and are listening to how to publish and how to do research. So I hope Anil has sorted out his thing. Are you able to? Yeah.
Thanks, Anil. I will try again. I just made a quick phone call to our technical man to try and sort out the issue. You see, the problem with us is that we are spoiled. We have so many people working for us that we never get a chance to really learn the basic technology. What I wish to state, Mr. President, is that our previous, very reputed speakers, they have actually covered most of what I wanted to say already. And secondly, my talk is in the form of a recording with the IAGES, which is used for the fellowship program of the IAGES whenever it is required. So in that sense, can be done again at any time. I am conscious of the fact that we are out of time and it is late night. So with your permission, maybe we can play it the next time whenever we have the program again.
If it is playing tonight, we are happy to have it. If it is...
No, it's your call. I mean, since it is late night and we are past time.
Please go ahead. Please go ahead.
Okay, so I will try and share screen again and go to screen again. Oh dear. It doesn't show me screen. Now I've clicked on share screen, but it doesn't take me to my laptop, desktop, which is where I want to go.
Nathan, can you help and share out?
So I've clicked on share screen, but I need to get to my desktop, which I'm not able to do. So if somebody can sort this out, it is fine. Or it says screen, and it shows me Dr. Sunil Popat. That's done it. Well done. Okay, so that is my recording. Can you hear? Can you see and hear now?
We are unable to hear you, sir. Maybe you can run as a commentary by yourself.
Okay, let me try and increase them. This is on maximal volume.
No, sir. The issue is you are using a headset, so the audio may be shared to your headset rather than the presentation as such.
So I stop it then, is it?
No, sir. You just you can talk to your presentation, sir. That should be perfect.
Okay, so do you want me to? Can you see my screen?
We are able to see your video, sir. You can please narrate it by yourself, sir.
Okay, so let me put my thing to low. Okay, so the role of a surgeon has now changed, from being a doer to a thinker and a teacher. So what to write has been discussed already by my friend, Dr. Aman Goel, and this is just a list of things that one can write towards publication in a scientific journal, starting from the most simple to the most complicated, the letter to the editor, and then the case report, the surgical technique, the case series, the case control study, the cohort study, the randomized control trial, and the reviews, and finally, meta-analysis and the editorial. So this is a list of things that qualify as scientific articles for a medical or a surgical journal. Now, the case series, the case control study, and the cohort study, these are non-randomized observational studies. And of course, one has the randomized control trials and the narrative reviews and the systematic reviews and Cochrane reviews, and finally the meta-analysis. So let me see if I can go a little forward on this. Okay, so we've talked about these. And of course, they were narrative reviews, the systematic reviews, the Cochrane reviews, and meta-analysis. These qualify as review articles in a journal. So, well, first of all, when you start, you must formulate what is known as the study protocol or the research protocol. And the research protocol should be a document that is readily available in all teaching hospitals throughout the country. This, once you have prepared your study protocol, this has to be submitted to the local institutional review board. You have to have written consent for your study, and like Dr. Goel said, your study has to be registered with the Clinical Trial Registry of India. And this is just to show you what the study protocol normally comprises: the study objectives, which is why are you doing the study design. It talks about selection of participants, what you are going to do to the participants, how will you measure what you want to measure, what are the safety parameters that you have in place for your study, what sort of statistics you have used, and things like the participant rights. So you don't write because you want to say something, you write because you have something to say. And when you have something to say, the shorter, the better. Okay, I just wanted to reiterate the fact that I'm not a sexist, but I put up such pictures only to keep my listeners engaged. That is the only purpose. So please excuse those who feel offended. Now, the message here is the shorter the better, because we all know publication space comes at a premium. But more importantly, the attention span of a reader now is very short. So you have to try and give your message in a very short and succinct manner. So this slide shows you about the levels of evidence, like we know from level 1 to level 5. These are levels of evidence. And this is something that most people would be aware of. So now, to start for a new writer, a new researcher, I think somebody who is writing perhaps for the first couple of times should have a look at these three possibilities: the case report, the case series, and of course the how I do it, because these are the most simple to write when you start off writing. So if you can't explain it simply, you don't understand it well enough. So the main idea here is to write simply, that in a language that can be readily understood. And this is the basic structure as it exists for all scientific writing, the IMRAD structure. And this consists of the following things: the introduction, which is normally about 2 paragraphs; the method section, which normally comprises 5 paragraphs; the results is normally 7, and discussion is normally 6 paragraphs. So one has 20 units of thought to prepare. Now, the main concept about breaking it down like this is that you can treat these as 20 separate units that have to be written. So take 1 unit at a time. That is why we try and break up the entire article, so that you can just concentrate on 1 unit and not think about the entire article, because that gets you confused. That takes a lot more time. So the first segment is the introduction segment, which says, why did we start? So 2 paragraphs of introduction. The first paragraph, you must state what is the current knowledge on the subject, what is known already, what has been studied already, what has been published already. The second paragraph derives from the first paragraph, where you can pick up a small point that is still not very clear, that still needs a little elaboration. So your reason for doing your current study can stem from the fact that there was this little lacuna, perhaps, in what is known already, which is what you wanted to clarify, and that is why you are doing your present study. So the last sentence of the second paragraph should normally be, the aim of the study was so and so, or should start with, we report so and so, or we reviewed so and so. The second segment comprises the method section of an article. Now, when you write about the methods, you are writing about what did we do. So the story of what the authors did, the story should come in a logical framework of time. So you first made the study protocol, you took consent from the local institutional review committee, You then selected participants. You then conducted your intervention. You then studied these parameters. You then followed up patients, so and so. So this should all come in a logical framework of time. And in the methods, you have to be very clear. You can have one or at the most two primary endpoints, but not more. And secondary endpoints can be more, maybe 2 or 3 secondary endpoints as well. But the lesser the endpoints, the better it is. So these comprise the 5 paragraphs for the method section. Paragraph number 1 will talk about study design. What sort of a study is this? Paragraph number 2 talks about your patients, which patients were recruited into the study, who were taken, who were left out, and why. What sort of an intervention was done? What were the outcomes that were assessed? And finally, what were the statistical tests that were used? The next segment is the results segment, which basically addresses the question, what did we find? So here in this section, you just talk about what you found. And this has to follow the same logical framework of time. Your results section should be a mix of text and some numbers in the form of graphs, in the form of tables. Make it more visual, more interesting. And again, be concise. The final segment comprises discussion. So when we talk about discussion, we address the question about, so what does it mean? So these are the paragraphs that comprise the discussion section. The first paragraph normally is a concise summary of what you did and what you found. You then talk about limitations of your study first. Upfront, you must let readers know about what are the limitations of your study. And believe me, there would be a lot of limitations. Maybe patient numbers are small. Maybe the follow-up was in fact limited. Maybe there were some parameters that you missed out on. So many limitations of the study, state them up front. Be very cautious when you talk about strengths of your study, but then if there is some aspect of your study which you think hasn't been done before, you can mention it up front. Then the paragraph on how it fits in. So we'll talk about what has been reported already in literature. Talk about similar studies that have been done before and how your study fits in with the rest of the studies. Where is it similar? Where is it dissimilar, and why? This is segment on discussion. You must also let readers know why you think your results are similar or dissimilar. Discuss all of that. And then finally, what are the implications? So you have done a study, you have come to certain conclusions in your study. So what are the implications? What are you saying? What should change? Should there be a change of your clinical protocols? Should there be a slight change in patient management? Should there be something we are doing differently? What do you think needs to change? So the final paragraph is normally the paragraph on conclusion. This should be relevant and consistent with data. your segment of the introduction should corroborate with what you state in your conclusions. You cannot state things in your conclusion which you have not studied in your article. You cannot conclude things which you have not studied. This is a very common mistake that is made. So while referencing, of course, Vancouver style referencing is the commonest. And now the role of a biostatistician. Now, the biostatistician is a very important figure, and that is because he should be involved right from the beginning. You should not be in a position where you first do your study and then call your biostatistician to try and make some sense of the study. It doesn't work that way. So the role of a biostatistician, he actually helps you with your study protocol. When you are first preparing your study protocol, he keeps looking at the data that is coming, into your data bank for the study. He keeps telling you about what things are going right and what things are going wrong, what parameters are being entered, what are not being entered, and so on and so forth. But then if you ask me in one simple question, the role of a biostatistician is to sex things up. They make simple things look much better. That is the magic of a biostatistician. So how to get started? First of all, there should be a clear message that you want to deliver. And there should be only one message per article. The research question, like was told to us, just some time ago, is the picot, which is what patients, which intervention, then how does it compare, and finally the outcomes. It is known as the picot questionnaire. If you have clear answers to those 4 points, you will by and large have a good message to give. For example, this is a good message. The gallbladder removal from the umbilical port leads to a greater incidence of port site hernia. So simple, straightforward message. Transabdominal sutures to fix meshes and laparoscopic incisional hernia repair leads to more postoperative pain. So a simple, succinct, straightforward message. So this has been talked about, so I won't talk about all of this. We know about all of this. So before you have completed your article, ensure that you talk about the approval that you have received from your ethics committee within the article. Your study should have been registered on CTRI, which is the Clinical Trial Registry of India. Now, just a few facts about data management. Basically, it's being very careful about what data you collect, because that will in fact determine what data comes out in the article. And like was in fact mentioned before, the most common way of putting in data is into a Microsoft Excel worksheet. And they were multiple choice sort of entries work the best, because then you need much less time to fill up your data. This is what a Microsoft Excel worksheet looks like. Of course, there is various software available in the market that I'm not very well aware of, to be honest, which you can use. And like was in fact mentioned earlier, I think Professor Sandeep Agarwal said that we have guidelines which are readily available on the internet. So for systematic reviews, you have Prisma guidelines and so on and so forth. These are freely available on the internet, and these would help you to, in fact, ensure that what you have created is as per protocol. And this needs to be mentioned in your article as well. The fact that you have followed the so-called standard guidelines for your article, it takes your article that much forward. So it is the great leap of faith that you have to finally take if you have still not started to write scientifically and to write in surgical journals. You need to take one step at a time, but it is this great leap of faith into writing and publishing that will take you, much further ahead in your surgical career and be a source of great satisfaction to you in time to come in your profession. Thank you very much.
Thank you, Dr. Anil Sharma. Excellent presentation. And by listening to and looking at all the presentations, I think all the faculties have done great justice and given a very important source of information for anybody to start doing research and start getting into the real art of publication. And my compliments to Sandeep for bringing together excellent team here of all the important editors of various journals in India. And Anil, your presentation was very pertinent of actually how to write. I mean, we listened to all the presentation and everybody covered different aspects. And you actually wrote, how many paragraphs and what message should go. So I think that was very pertinent for a writer, how to write it and, how to send it to the journal. So excellent presentation.
Thank you.
Dr. Sandeep and Dr. Aman, you would like to have any comments or?
No, I think it was an excellent presentation, and it completes the proceedings of the day, because ultimate aim of research is publication. So right from how the articles get rejected and how it should be written, I think Dr. Anil has done a great job. It will be people who are beginning to start research, for them it's a big help. It will be of big help to them. Yeah, thank you.
Thank you, sir. President sir, can we move on to the Dr. Ishwar's presentation?
Yeah, sure, definitely.
Ishwar sir, over to you, sir.
Okay. Can you see my slides, sir?
Yes, sir. Yes, sir.
Thank you. Thank you, President. Thank you, Kanakavel. My dear viewers, ladies and gentlemen, even though it is quite late in a day, I'm sure, thanks to our President Kanakavel, I think we had a perfect New Year gift by bringing all these 4 stalwarts today, who are all in their own merit, has done so much of research, sharing their knowledge, giving us all the tips and tricks of how to publish. I think we should start thinking and putting all our thought process in paper and start publishing, not only in our JMAS, and also whatever appropriate journal you see. So we send our heartfelt appreciation and appreciation certificate on behalf of our IAGES EC to Dr. Anil Sharma, Dr. Sandeep Agarwal, Dr. Rajiv Kumar, and our past president, Dr. Aman Goel. Thank you very much for having joined. And it's my pleasant duty to give you a couple of things before we close the day. Of course, the next week, we are going to continue to be busy in spite of the COVID or the Omicron is on the other end, but we are going to travel to Hyderabad, and all the people in and around that area, please join. And Dr. Lakshmi Kona with her team, with our president and our Safe Lab Poli team is there in January 8th and 9th, showing so much of the basic things along with the live workshop on a Sunday with the more than 3-4 cases will be sold. It's a perfect, I think, way to start the year 2022. And following subsequent weeks in 21st and 22nd in same Andhra Pradesh in Vijayawada, if you are going to be able to come and see us, we'll tell you all the tricks of the trade to repair the groin hernia and abdominal wall hernia with all the stalwarts in that field with a live workshop on the following day. So mark these dates and please join us, and we'll be with you with all the people shown here. And people who wanted to come to Rajamundry, yet to have some breathing space to have the FAGES, because quite a few people are already done falls program. We have done 5 falls programs, advanced laparoscopy. There are a few still wants to do this is the last and final FAGES. I mean, there is one more after this in Dehradun in February, of course. This is the one in the Trivandrum by Dr. S.K. Ajay Kumar on 28th, 29th, and 30th of January. Please, all these things are available both in our website and also in the mobile app. And if you're a person who has done a lot of research relevant to today's talk, we are having academic initiatives from IAGES, like a Best Postgraduate Thesis Award for this year. 5 such award thanks to Professor Gani Bhaskar Rao from GSL. We are going to offer 1 lakh cash reward. It will be awarded. The last day is just 2 days away, 31st of December. Please submit by a Google form, and I've sent the link already to all of you. And also, if you're an IAGES member and you have done a lot of research this last 1 year, and this still there is a time left, and in the next couple of days, please submit your Google form, and we'll be doing all the things to choose best of 5 of you to get a cash reward along with the appreciation certificate during our conference and convocation in Rajamundry on 10th to 13th of February 2022. So please, on behalf of the organizing team by Gani Bhaskar Rao, Samir Ranjan, and the whole team, and with our president and all our EC, we want to see you there, because it's going to be the 8 halls, 4 days. I'm sure there will be an academic feast, and dedicated halls will be there. And also, as I said earlier, even if you're a delegate, there is a way to get a best video, best poster, best free paper presentation, and a golden chance to win 50,000 each for best paper of this. So there is a plenty there also for you. So as I said, it's going to be 8 a.m. to 8 p.m. session every day, packed. In the morning session, for a change, we are going to have a live operating session, 4 parallel halls, 2 days. So it will be 8 a.m. to 1 p.m. Then in the afternoon, we are going to have the state-of-the-art lectures, debates, panel discussions, and master videos. So the online is open, and I'm sure it is a big venue, as you can see, and the new big hall with a capacity of 1,500 delegates are there. So a lot of people are expected, both the national and international faculties, and I'm sure you started booking your flights. We want to see you there. Till the time, on behalf of IAGES and also for Doc Pluses who have done the seamless transmission at another time, and for Aman Goel to coordinating, and Dr. Sandeep for bringing this webinar, and for our president to have this leading from the front. Thank you. Bye-bye. Good night.
Thank you, Ishwar, Aman Goel, and all faculties.
Thank you. Good night. Thank you.
Good night.
Good night.
Thank you, Doc Plexus.
Thank you, sir. Thank you, everyone.